Okay. Now it's not a hectically long presentation or anything like that, so nobody's going to fall asleep. Hopefully, it's about COVID vaccines with cancer and COVID vaccines with chemotherapy. Okay, and the reason I thought this would be important is because there's every single one of the patients I see, this is part of the conversation. Okay,
Yes.
so I thought we can do that. All right, so in a nutshell, we are dealing with, in essence, it's just right. What the vaccines are designed to do is they're designed to trigger an immune response in order to fight the foreign invader when the body sees this said foreign invader again. Okay, so mRNA vaccines teaches the cells how to make a piece of protein or a protein that triggers the immune response. These vaccines are given as 2 doses, a minimum of 14 to 21 days apart. They are 100% effective in preventing COVID-19 after the second dose. So you'll need 2 doses to get complete protection. And that means that once you've had 2 doses of the Pfizer vaccine, you should not land up in ICU with COVID, neither should you die from COVID. And at about 6 months, you will find that it's still 91% effective. So it's pretty good once you get that vaccine. And I believe these are the vaccines that all the elderly folk, in other words, over 60s, got in South Africa. Well, those who went and got it done. Okay, now the spike proteins are proteins that coat the outside of the coronavirus. And one of the reasons they exist is in the coronavirus, they used to infect the cell, invade the cell, and start replicating within the cell. So this can easily be a target for our immune system. Now, anything that uses a spike protein uses a single dose of vaccine. So the J&J vaccine is a modified human adenovirus that can no longer replicate. It is 66% effective in preventing severe or critical disease, and it takes about a month before you get protection. So it's interesting in that it takes, after 2-3 weeks, you get about 100% protection. And then what happens is slowly it decays. And even at about 6 months, you have about a 66% protection from severe or critical illness. All the people on the J&J vaccine trial, none of them died. Okay, so it is very effective and it works by about 14 days. So 14 days after you've had your vaccine, you're good. You're quite well protected. This vaccine is now the vaccine that's being rolled out to teachers. Okay, so that's the one the teachers are having. In April, on the 23rd of April this year, there was a blood clot advisory by the Federal the Food and Drug Administration. And the reason they put out this clot advisory is because 6 women between the age of 18 and 48, out of the 6.8 million doses administered, developed clots in their brain. Okay, and the reason they put out this advisory is to tell people you must not anticoagulate these people who've had clots because they'll die from the anticoagulation. So that's why it was stopped. It wasn't stopped because it's bad for you. It wasn't stopped because it causes death. And I mean, your incidence of getting clots from COVID itself is about 10 times higher than that. So just to put it in perspective. Okay, so what are the recommendations for people in this field? Well, it's well described that cancer itself is an independent risk factor for a worse outcome from COVID-19. So what that means is that if you've got cancer, the fact that you've got cancer alone portends a poorer outcome for you. So it implies that you're going to do worse, okay, if you get COVID. So that's number one. Number two, it doesn't matter if you're getting treatment or not. So if you've got cancer, whether you're on treatment or not, you're a poor prognosis group. So what do we do if you're newly diagnosed? So we tell patients who've just been recently diagnosed, please, if you're eligible, get the vaccine before we start your treatment. And it's advisable that you get it at least 2 weeks before having had chemotherapy. Okay. Now, that's, say you've been newly diagnosed and you're still in the process of getting all your scans done, authorizations for treatment, you're not yet going to have surgery, all of those things. The ideal treatment, the ideal time for you, to get your vaccine is now. What about the majority of the people we see, i.e., the people on chemotherapy? Well, we shouldn't be changing too much in terms of the chemotherapy treatment plan. We have to time the vaccine. We must time when we give you the vaccine or the chemotherapy, whichever one is more amenable to be changed. Okay, so it's important to make the timing correct. So the first thing is you need to resolve the neutropenia. So if you've had chemotherapy and your blood counts are low, so your neutrophil counts are low, that first needs to be normal. Okay, and then the other thing you need to be able to tell people is that there can be many things that go wrong with you when you get the vaccine. You can get allergic reactions, you can get blood clots, stuff like that. And that, in essence, is almost the same as if you were having chemotherapy. So the chemotherapy itself can also do that in the scenario, and that's important to know. Okay. The next thing is sometimes it's very difficult to work out when you're on chemotherapy, which would be the chemotherapy side effects and which would be the side effects that you get from the vaccine. So what we tell patients is if they're getting chemotherapy, we try to give them the vaccine before their chemotherapy or a week after their chemotherapy. And hopefully then the next chemotherapy is in 2 weeks' time, in which case your immune system is then okay enough to mount a response and give you enough stimulation to give you antibodies. Okay, and that would be great. Okay, then what about after chemotherapy, and what about after immunotherapy? Well, there is conflicting data on immunogenicity post chemotherapy. So, what if I gave you chemotherapy today, and they phoned you up or they sent you your SMS and they said that, listen, you are now good to have your treatment. What happens? Okay, so the recommendation is that you have at least a week from the chemotherapy to when you get the vaccine. Okay. Now, the data with immunotherapy is different. Okay. And the data with immunotherapy is different because sometimes it shows that toxicities are worse, and sometimes it indicates that toxicities are not worse. Okay. And the reason for this is very simple. Immunotherapy treats people by stimulating the immune system to attack and kill the cancer. That's exactly what the vaccine does. The vaccine produces a foreign body, so the immune system recognizes it. So when the immune system sees that foreign body again, it knows that that's the foreign body it needs to attack. So theoretically, toxicities are worse. However, I have seen personally from all the patients that I have on immunotherapy, on the Pfizer vaccine, they just flew through it. None of them have had poorer toxicity. So that's interesting. So the recommendation is to continue with vaccination, okay, whether you're on immunotherapy or chemotherapy. Now, none of the vaccines, not any one of them, have specific approval in immunocompromised patients. So what does that mean in a nutshell? It means that if you look at the package insert, none of them will be saying to you, approved for administration with chemotherapy, approved for administration with immunotherapy, none of them. So it's important to know that this is just from all the data that we have on patients that have received it. Okay, so What is the problem with an immunocompromised patient? Well, you have a problem with how the immunocompromised patient, the host, if you want, responds to the vaccine. That's your big problem. So the big problem is that you need a functional immunity, right? You need to be able to present what we call antigen to the immune system. Now, the antigen is that piece of the bug. If it's the bit of RNA, if it's a spike protein, whatever, the immune system has to recognize it. So if the immune system recognizes it, the T and the B cells in your system will activate, and the plasma cells will make the antibodies. When the plasma cells make the antibodies, that's when you have, in inverted commas, immunity. And that's how a vaccine works. So there's no adaptive immune cells to impair the vaccine effect. Okay. Now, the problem is that sometimes you can get a hyperimmune response, right? Now, especially with mRNA vaccines. This was seen in mouse models, okay? And it was you're worrying about it, especially in patients getting immunotherapy, because they can get a hyperimmune response and you get autoimmune syndromes. Well, that's not been seen in humans. That's only been seen in animal models. So what do we tell people? We tell people in essence that when we look at this is all a cost-benefit analysis or a risk-benefit ratio. So we know that number one, the benefit, we'll get to that now, of receiving vaccines is that if you get a good vaccine, and please be aware that so far South Africa has only got good vaccines. So we've only ever got Pfizer and the J&J ones. We've not received any Chinese vaccines, which are, according to sources, a bit questionable. And we've not received any Sputnik vaccines, and none of you are going to be launched into space. So far, we've only had good vaccines. Not a lot of them, but only the good ones. So if you look at all of those things, we can see that the benefit after the 2 doses of the Pfizer, or even the 1 dose of the J&J, is that it gives you protection. So why is that important? Well, the answer is very simple. You need to look at this like a can of jelly beans. Say you got 100 jelly beans in the can, right? And you know that 2 of them, if you eat, you will die. But you don't know which 2. What would be the solution? We all should stop eating jelly beans. Okay, until we can work this one out. That's the reality. This is what COVID is. So it isn't going to kill everybody, but it's certainly going to kill a fair number of people. And if we can avoid that, simply, this is the only way to do it, because you can't identify it any other way. Okay, so that's the risk, the benefit. So what's the risks? The risks of having the COVID vaccine, excuse me, is that you can get pain in the injection site, a little bit of swelling, a little bit of redness. Some patients get tiredness, headache, muscle pain, chills, joint pains, fever, nausea, unwell, and even lymphadenopathy. So I've had that in 1 or 2 of the staff members, because I've made sure that the staff members of the practice all have been vaccinated. That's important, because when the patients come there, I can't have the patients being put at risk. Okay, and that's the reality. The reality is that patients are coming to the units and they're trusting you with their health. So I can't have a situation where the people who are looking after them, for any reasons, have decided, no, I don't want to be vaccinated, or I can't go for the vaccine. I'm not prepared to stand in that queue for hours and stuff like that. So that's what the situation is as regards the COVID vaccine. So I'm not going to say anything more at this point. I shall stop sharing and I shall open the floor to any questions around specifically vaccines, COVID vaccines, and cancer.
Great, thank you so much. That was really, really informative. Thank you, Dr. Moodley. Okay, ladies and gents, who has questions? You can put your hand up, you can unmute yourself and let us know, or type in the chats, whichever you want to. Any COVID vaccine and cancer related questions, now is your time. So let us know any questions. Yes, Lou.
I just want to make a comment. Devon, thanks for joining us, firstly. Secondly, a couple of us on this group today have already been vaccinated, most of us with the J&J.
Yes.
So far, the cancer survivors have less side effects than the rest of the staff.
Yeah, that's true.
Which I found interesting. As survivors, we did far better than the actual staff.
Okay, so
cancer patients.
Very simple explanation. Okay, so everybody with a fully functional, robust immune system, right? They recognize this little bit of virus as foreign. They put the whole fully functional immune system into practice to get rid of that bit of crap, if you excuse my French. Right. So that's what it does. Right. All the cancer survivors have had trauma to the immune system. They've had the trauma of the cancer. They've had the trauma of the treatment. They've had the trauma of immunosuppressive therapy. All of that has dampened the immune system. That's why they're immune compromised. They cannot mount as strong a reaction to this invader as normal immunocompetent people can, right? And therefore, their reaction to the virus is muted. So now what it has done is exactly what a vaccine should do. It has primed the immune system to say, listen here, I've told you once already. Are you listening to me? This, when you see, is not good. Okay, so all the people have got together. They've had a long discussion. The immune system said, okay, we agree. This is not what we want. So now they're recruiting all their forces. So if they find it again, then it can attack that. Okay, and that's why you are right. I mean, I've had healthy people that have had horrific side effects. And all of the patients who are a little bit immune compromised, they just sail through it. Okay, it might also explain why there's a difference between the mortality, for instance, in Europe and the mortality in Africa. Okay, now please understand, I'm not for 10 seconds diminishing the mortality in Africa. Okay, not as many people in Africa has died as, for example, in Europe. You've seen the TV bits. You've seen in Spain and in Italy and all of that, and how the people have died. Okay, why? Because these elderly people have lived well. They have nurtured and looked after themselves. They have robust immune systems. When the virus gets them, the immune system reacts very, very properly. And they have lots of side effects from actually the reaction of the immune system to the virus. Okay, and that's why they land up in ICU and stuff like that. We've had many, many immunocompromised patients in this country, although it's a risk factor. So if it overwhelms you, it's a bit difficult. But if your immune system doesn't mount such a big reaction, you don't get so many problems. Okay, so they don't land up with big, big, big hassles. Of course, that's a very simplistic way of looking at things, right? Do not take it as gospel for 10 seconds. But what I can tell you is that with a little bit of a dampening in the immune system, we actually do better. Indeed, it's how we treat patients with the virus. So if your CRP is high, if your IL-6 is high, we give you cortisone. Why? The cortisone is an immunosuppressant because we don't want your immune system going wild. Okay, so the virus in the vaccine, the killed virus, the bit of the virus, is there to teach the immune system to look out for this. So when it comes, it kills just that. What happens when you get an infection and no vaccine? It doesn't know what to do, so it goes wild, making antibodies and stuff that attacks everything.